Okay, so welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record that Karen San-Hilaire is representing Gary Jenkins and Dr. Michelle Morse is representing Dr. Ashwin Basan, both in a voting capacity. So next on the agenda is the adoption of the minutes of the board meeting held March 31st, 2022. Are there any questions or comments? Can I hear a motion to accept the minutes?
Second.
Thank you. Let me then ask for your vote one by one. Dr. Katz,
Yes.
Ms. Kelly, Erin Kelly?
Yes.
Thank you. Vincent Calamia,
Yes.
Patricia Martone,
Yes.
Michelle Morse?
Yes.
Michael McRae,
Yes.
Karen San-Hilaire? Karen? Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Excuse me, I'm sorry to interrupt, but I don't know who's
Yes.
talking. I don't know who's talking.
Jose, I'm sorry. Jose.
And so you'll have to tell me your name?
Yeah, I'm sorry. Yeah, my name is Jose Pagan.
Pagan? Okay.
Yes. So Sally Hernandez Pinheiro and Anita Kawatra.
Yes.
Thank you. During the executive session, the board received and approved oral and written governing body submissions from NYC H&H Queens. The board received and approved the 2021 Performance Improvement Plan and Evaluation. This is a written submission from East New York Diagnostic and Treatment Center, Gotham, and Rehabs and Rehabilitation Center. The board received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals, Coney Island, and Elmhurst. So let me continue. According to Article 6, Section 3B, at each meeting of the board, the executive committee shall make a report of all actions taken by it since its last report to the board. I would like to report that the executive committee convened on April 5th, 2022 at 4 p.m. and considered and approved the following two items. Authorize the execution of a contract with Gemco Electrical Contractor for construction services necessary for the decanting of the sections of Woodhull Hospital Center to facilitate the outposted therapeutic housing unit for an amount not to exceed $30,690,760, which includes an 8% contingency of $3,130,858. And it also authorized an increase for funding for 7 construction management consulting firms: ACOM USA Inc., Arman Corporation, Gilbane Building Company, Jacobs Project Management Company, McKissack and McKissack, TDX Construction Corporation, and the McLeod Group LLC. And these are called together the vendors to provide professional construction management services on an as-needed basis by $40 million to bring the limit for all vendors to a new amount not to exceed $50 million. Both items were presented to the Capital Committee on March 14th, 2022. Do any members have any questions or further clarifications on these items? The full presentations, by the way, were included in today's meeting materials. So next on the agenda is the, let me see. So I'm sorry, please be aware that fiscal year 2022 annual public meetings for the Borough of Queens and the Bronx are scheduled for May 10th and May 17th, both starting at 6 p.m. All relevant information is listed on the public website. So let me move on to VENDEC approval. Since we began the process. Okay, so VENDEX approval. Since we began the process of approving contracts prior to VENDEX approvals, there are five items on today's agenda requiring VENDEX approval, of which 5 have the approval. There are 10 items from previous board meetings pending VENDEX approval. Since we last met, no approvals were received. We will continue to notify the board of us as outstanding Vendex approvals are received. So let me do the adoption of the minutes for the executive committee meeting held on April 5th,
Sir,
2022.
Dr. Pagan,
Yes.
I'm not used to this terminology, so if I could ask you to slow down a little bit so I can
Okay.
understand what you're saying? Thank you.
Thank you. Okay, so let me move on then to the adoption of the minutes for the executive committee meeting held on April 5th, 2022. Are there any questions, comments, or changes? So hearing none, let's then have a vote on that. Dr. Katz?
Yes.
Give me 1 second. Hold on a second. Got the wrong page here. Erin Kelly?
Yes.
Thank you. Dr. Calamia?
Yes.
Dr. Marthone?
Yes.
Dr. Morse?
Yes.
Dr. McRae?
Yes.
Karen Saint-Hilaire? Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Anita Kawatra?
Yes.
Jose Pagan, yes. So the minutes from the executive committee were approved. Let me move on then to our resolutions. Let's see here. Actually, I'm sorry. Let me move to informational item on maternal health. Thank you. Dr. Allen and Dr. Wilcox. Higgins, McCoy. Please go ahead. Yeah.
Thank you. Good afternoon, and thank you for this
Chris.
opportunity to present an update of the maternal mortality.
Does she need to introduce herself?
Yeah, please
Oh, I'm
introduce.
sorry.
Yeah.
I'm Dr. Wendy Wilcox, Chief Women's Health Officer.
Can you all introduce yourself so that the board knows?
Sure.
I'm Jennifer Havens. I'm the Director of Child and Adolescent Behavioral Health in the Office of Behavioral Health. I'm Mary McCord. I'm the Director of Pediatrics at Gotham Health and at Sydenham.
And I'm Dr. Michelle Allen, the
Excuse
Assistant
me.
Chief Medical
Excuse me, you're
Officer.
not coming out clear, Dr. Haven.
Yeah, you need to turn on the microphone. Yeah, sorry about that. Yeah.
I'm Dr. Jennifer Havens. I'm the Director of Child and Adolescent Behavioral Health in the Office of Behavioral Health.
And I'm Mary McCord. I'm the Director of Pediatrics at Gotham Health and at Sydenham.
And I'm Dr. Michelle Allen, the Systems Chief Medical Officer. What we'd like to do today is share with the board collaborative work that's being done to address maternal mortality and morbidity. It's a collaboration between Women's Health Services, pediatrics, and child and adolescent psychiatry. Dr. Wendy Wilcox will initiate our conversation this afternoon.
Thank you, Dr. Allen. Good afternoon. Since 2001, as you can see from this slide, at the top graph on the slide, there has been a drop in pregnancy-related maternal mortality. The top line is pregnancy-associated maternal mortality, which encompasses all deaths within a year of termination of a pregnancy. The lower line, the red line on the top graph, is the pregnancy-related mortality, and those are mortalities related to causes related to a pregnancy, such as a hemorrhage or a cardiac event. Since 2001, you can see that there has been a decrease of 34% in pregnancy-related maternal mortality. Directing you to the lower graph, however, the disparities between Black and white maternal mortality persist. In 2000, the lowest we have been in the latest 2 years, 2016 to 2018, actually mirror what we had between 2001 and 2003. However, the average pregnancy-related mortality ratio is 9.4 over the course of many years, and you can see that it goes up and down. Next slide, please. Now, there were two main pillars of our approach to our program to reduce maternal mortality and severe maternal morbidity. One of them had to deal with simulation. As you know, we have a corporate simulation lab, which is located at Jacoby. However, with funding also from City Hall, we built 6 mini labs in 6 of our sites, and you can see them listed there. These were mainly our trauma centers and sites of the largest number of deliveries. We actually developed courses that attack the top 3 causes of maternal mortality, or at least the top 3 causes at that time. One was OB life support, which dealt with cardiac events in pregnancy. The next was OB hemorrhage, and severe hypertension is the third. We've actually completed hemorrhage and OB life support. Severe hypertension approach is going on now. We've partnered with Health Scholars, which is a company that develops virtual reality simulation, and we're actually on the cutting edge of technology, and they're the first to really offer OB simulation in a virtual reality platform. This work is so notable that it's being presented at 2 national conferences. One is the American College of Obstetricians and Gynecologists, and the other is the Association of Women's Health Obstetric and Neonatal Nurses. Next, please. And that's a picture of a virtual simulation right there. The next pillar of our work dealt with something called the maternal home. The purpose of the maternal home is to give patients wraparound services, pregnant persons who have need for support. And this support is either due to clinical reasons, behavioral health, or factors related to social determinants of health. It was started in 2018, and we staffed it with social workers and maternal care coordinators. They were very active throughout COVID-19. They checked in on patients who were discharged home with COVID. They advised patients where to find supplies that were in short supply for themselves and the babies during the pandemic, such as diapers, formula, and wipes. And they helped direct patients to food banks. It has been implemented in 11 of our maternity hospitals. Next, please. Next slide, please. So, highlights of the program. We originally estimated 2,000 patients that we would see over 5 years. And at the end, December 2021, we had seen over 3,000 patients in 2 full years of the program. In 2021 alone, we reached 2,195 patients, which represented 16% of all the births within health and hospitals. The largest cohort of patients served were in Brooklyn, where 25% of the patients were in the maternal home. Patients were served in 19 different languages. 75% of them were Black or Hispanic.
Somebody's
And
phone is
the
on
bulk
and it's
of the
getting
referral-
echoed.
The bulk of referrals for medical support and management, 59% were to dental, 28% were to 321 Impact, which you will hear about in a few minutes. The next were parenting and pregnancy support. We made 22% of referrals to doulas, and 13% to the patients to the nurse family partnership. And for social determinants of health, we directed 62% of our referrals to food support, including WIC, SNAP, and food pantries, and 11% of patients were referred to mental health services, as well as 11% to housing. Next slide, please. And now I'll turn it over to my colleague, Dr. McCord, to talk about 321 Impact.
So the 321 Impact program, which stands for the Integrated Model for Parents and Children Together, is a program that brings all the children that we take care of in primary care pediatrics together with a link to the prenatal services, and particularly to the maternal home, into a single sort of bubble of support that supports the mother and the child and the family. We've increasingly realized in pediatrics and primary care pediatrics that our job is supporting the long-term development of children, optimal social, emotional, and developmental outcomes. That includes health, but it also includes mental health, and that the way we do that is by supporting parents, to be the best parents that they can be. This program, the visual there outlines the program where it sits in the clinical services. So in pediatrics, you can see the menu of things that we're doing. The top 3 are evidence-based programs that support parenting. We take advantage of the care that's being given in prenatal visits, the very frequent visits, and then, and this is important, we've paid a lot of attention to the handoff between prenatal care and between pediatrics so that the support that's initiated now in a much more robust way with the maternal home is picked up seamlessly and continued while the child is in pediatrics. The number one need that we find with screening, which is an important part of the program, and also with the clinical assessments, the number one unmet need is behavioral health related. And because it's very hard to access those services, integrating behavioral health services into the two settings, really primarily into women's health, but with a pathway for access for parents from pediatrics into women's health is a key part of the program. It is all based on the concept that we are assessing for needs and connecting to services, some of those services in the practice and some of them in the community. We take advantage, as I said, of the visits, and we've also built in community health workers so that we have a fairly robust care coordination for families if they need services in the community. It started as a pilot program at 3 sites, Bellevue, Queens, and Gouverneur, supported by funding from 3 sources: Robin Hood, New York City Health and Hospital Venture Funds, and the Mayoral Office of New York City Opportunity. It uses a risk-tiered approach so that support intensifies as needs are identified, but all families get some degree of support. As I said, it uses evidence-based models. And it brings in new roles into primary care, particularly the community health workers, social workers, and early childhood specialists, often psychologists, and then the psychiatrists who are in women's health more. Next slide. The key to the concept of the program is that this is the way that we deliver primary care. And so we need to figure out a way to support that, for the reimbursement for primary care, to support the work that we're doing. We think that if we can improve billing a little bit, and Dr. Havens will talk about that in a second, that about 50% of the services that we deliver will still be non-billable. And that's because some of them are from non-billing providers, community health workers, for example, and some of them are from mental health providers, but for services that are not mental health therapy services and so not billable. And we have to figure out how to pay for that with some kind of an alternate payment model. We think that that's going to cost about $25 to $35 per member per month, though we need more work on the actuarial models there in order to cover, as I said, all children in primary care and prenatal mothers. And that includes any increased cost of billing for the therapy services as well as the non-billable services. We're working on specific models with our managed care partners, drafting different approaches with Metro Plus and also with Health First. And this is a program that would work with our currently attributed members, but to cover this more robust model of care. There are three important advocacy opportunities. One is happening now, the 1115 waiver proposal. This is the new version of DSRIP. As you may know, DSRIP, the value-based payment experiment in New York State, had essentially nothing in it for children and for pregnant women. There's a little bit more in this waiver, but it needs to be more robust. 48% of Medicaid enrollees are in Medicaid, and currently the spend is about 9% on children. And while probably it's not going to be 50% on children, a modest increase in investment could have big returns through this type of a 2-generational model of care. This investment is going to require a commitment to long-term outcomes, not just the 1-year outcomes, and to cross-sector returns on investment. So some of the returns will be in the education sector, and longer term than that, even in the criminal justice sector, for example, as has been shown in programs like the Family Nurse Partnership. A key point here is that there's a known high cost. If we don't address these needs of young children, that leads to high cost later on. And there's good evidence that these programs can prevent those kinds of outcomes. The opportunity that the preventive well care visits in pediatrics and the prenatal visits offer is something that we're missing now, and that we should be taking advantage of to achieve these population health outcomes. And Bill,
Let's wrap it up, because
Okay.
I want to have board members to have a chance to ask questions, and we have a very long agenda today. So.
Okay, so just the good news on the billing. We were actually on the phone with DOH this morning talking about we all talked for years about integrated behavioral health and primary care and collaborative care, but it's actually very hard to do financially. But we are making progress on making it more feasible for social workers to bill, and really exciting, they have endorsed the concept that we should be able to bill for behavioral health prevention. So most of your visits in pediatrics are well-child visits. We don't have well-child visits in mental health, and we're moving towards that in New York State. And just to say finally, as a child psychiatrist who looked at a system where we wait 5, 10, 15 years for kids to get really sick, this is what we should be doing, because we know who these families are early and we can help them. And in the maternal child, mother-child setting, we can really help them. Thank you.
Thank you so much. Very, very impressive work, and I'm glad that you're thinking about all the components that go into it, including the payment side and disparities and all of that. So, plus all the simulation work, very impressive. Any questions from board members? Barbara Lowe?
Yeah, one of my questions were about the children's services, but you just wonderfully explained that. I'd like to congratulate you all on getting that in there as well. So thank you.
Yeah, there's additional advocacy to do around the new waiver, and we're working on it. Because
Don't forget the schools.
Excuse me, would you want me to identify each person that's speaking? Because I don't know who's speaking.
sorry.
Well, I'm Barbara Lowe. I was introduced by our chair before I spoke. I'm Barbara Lowe. I'm a board member.
But I don't see you and I don't see any names. I don't see anybody.
Hello. Can you see me?
Barbara Lowe.
Perfect. Okay.
Dr. Michelle Morse had a question. Michelle?
Yeah, thank you so much for the really incredible work, Dr. Wilcox and the whole pediatrics team as well. I just want to mention that we're aligned around your 1115 waiver priorities, which is very, very good. But the question that I had for you all was just from a New York City Health Department perspective. I didn't see on the prior slide that kind of mapped out preconception to age 3. It wasn't clear to me how nurse family partnership and some of the other health department programs like early intervention work with the model. I've heard wonderful things about the 3-2-1 impact model, but that part is still a little unclear to me. If you could say a little more about it.
Connecting to those programs is critical, especially those 2 programs. Nurse family partnership, the recruitment is all prenatally. And that's something that the maternal medical home has been very focused on, is recruiting into that, and also into Healthy Families America, which is a similar program that uses paraprofessional social workers instead of nurses, but also has good evidence for impact. They allow recruitment out to 3 months so we can recruit in peds. Early intervention, we have a very strong partnership. We're working with Lydia Ledniak, the commissioner for the Bureau of Early Intervention, to try and establish a closed loop referral system using our EPIC tools and our community health workers, so that we can track the referrals and support the parents at every point that they fall through the cracks, and that there are a number of cracks that those referrals can fall through.
That's really helpful. And is that integrated at all into the financial model that you're describing here, the alternative payment models, those 2 programs, NFP and EI?
Only in that the community health worker work to support connection to them, but and both the connection in women's health and the connection in peds being made more effectively, but we're not paying for the early intervention or the nurse family partnership through this model.
Thank you.
But that's a good idea.
It is a good idea.
Okay, so one more question from board members, and then if there's any. Thank you so much for the presentation.
Thank you very much.
And great work. So let me move on to item number 4 in your agenda. Dr. Calamia.
Thank you, Jose. Authorizing New York City Health and Hospitals Corporation, the system, to execute an affiliation agreement with Physicians Affiliate Group of New York, PC, PAGNY, for the provision of general care and behavioral health services for a period to commence on July 1, 2022, and to end on June 30th, 2026, at New York City Health and Hospitals, Coney Island, New York City Health and Hospitals, Harlem, New York City Health and Hospitals, Jacoby, including North Central Bronx Division of Jacoby, New York City's Health and Hospitals, Lincoln, New York City Health and Hospitals, Metropolitan, New York City Health and Hospitals, Kings, and certain New York City Health and Hospitals, Gotham Health sites. Collectively, again, the PAGNY fiscal year 23 to fiscal year 26 affiliation agreement for an overall total not to exceed amount of $3,800,390,000, including a 10% contingency. And this is being presented directly to the whole board for approval. Thank you.
Thank you so much, Dr. Calamy and board members. I'm Matthew Siegler, Senior Vice President, Health and Hospitals, and very pleased to be here with you today to talk about our partnership with PAGNI and the road ahead. So on this first slide, just a little bit of background on what PAGNI is and how we relate to our physician affiliates around the system. PAGNI is one of 3 affiliates. Our affiliation contracts cover professional services. They're primarily cost-based arrangements. However, this arrangement in particular moves us more towards incentive-based compensation, which we will talk about. And then finally, which we'll discuss more, PAGNI is unique among health and hospitals affiliates. It's the largest of our affiliates. It is also the only one not tied to another private health system in the city or a single academic institution. NYU and Mount Sinai are 2 other largest affiliates, but PAGNI is our largest. On the next slide, we lay out where PAGNI and our other affiliates work around the system. Typically, one affiliate has all the roles at a given site. Those a few are split, and PAGNI is by far the largest. So just a little bit of extra background on where they operate and how we work with them. Next slide, please. The team here, led by Dr. Allen, Andy Cohen, John Ulberg, and Deb Brown, have negotiated all 3 of our affiliate agreements, our 3 largest affiliate agreements this year, and they've all been guided by a set of principles that we're proud of and we think are reflected in the agreement that we are reaching with PAGNI. And just to go through some of those briefly, a heavy focus on improving the governance and management of the relationship, building an overarching governance and management structure, having clear and enforceable contract terms that are flexible enough given for us as needs change, having good reporting transparency, a major improvement for us in all these arrangements. On the financial side, a priority for all these arrangements was to align our financial incentives with the affiliates and physicians. I think we've achieved that excellently in this deal. And then to maintain sustainable compensation and benefit packages for our physicians and providers. That's an important point to underscore. These we want our physicians to, we want to retain our physicians. We want to be able to recruit them. So it's an important area of investment for our system. And we're pleased with the results of this negotiation to date. And then, of course, the most important, obviously, in any of these relationships is to support the clinical quality of the care delivered around our system. And so building coordination across our facilities and building out that patient care model, making sure we have attractive career opportunities for a diverse group of new and existing providers, given the age of our workforce, the diversity of our patient population. We are already and strive to continue to be national leaders in the diversity of our provider workforce. And Dr. Allen and I will talk about that a bit later in the presentation as well. And then finally, research and medical education are critical components of all of the affiliation agreements. So those were the guiding principles that we've been following through these negotiations. And then we'll take you through the results in the contract terms that we are finalizing with PAGNI. So on the governance and management side, we have reached agreements where the affiliates and our facility CEOs will have more management control over their budgets. Those budgets will be multi-year budgets. So it's very important for our facility CEOs and the affiliate leadership at the sites to be close partners, to be planning ahead with multi-year budgets and workforce plans. We will update the affiliate agreement language just to make them modernized and clear and understandable contracts, and then updating our governance structure at the system level. So we feel we've achieved all of those in this arrangement. Next slide, we go into some of the key financial terms. This was the primary area of negotiation with PAGNI, and it is an important step forward for the relationship. So our arrangement with them will work to transition PAGNI to a workforce plan-based budget in fiscal year 23 and beyond. That involves a multi-year budget and plan for what physicians will be required at each facility. So really moving from more of a kind of ad hoc filling vacancies as they arise mode to planful, long-range thinking about what we need at each facility and how we want to make progress together. We also, in this arrangement, set a guaranteed increase in provider compensation, which is very important to us to compensate our providers and increase their compensation in this critical time. We also invest in improving PAGNI's operational capabilities. Their recruiting and retention functions are very important, and they need a strong operational capacity to do that, and we think we are meeting that need here as well. And then, as we'll talk about more in the subsequent section, aligning our incentives to increase shared revenue for both PAGNI physicians and for the system at large was I think the major breakthrough in this arrangement. In the faculty practice plans that are currently present at each PAGNI site, we've had some major and important changes in this contract. PAGNI will be unifying its faculty practice plans and will have significant steps forward in new incentive-based compensation tied to value-based payment. As everybody knows, that is a central part of our strategy here at Health and Hospitals, and this contract really sets us up to be deep partners with PAGNI in our success in value-based payment. So we'll talk more about that as well. On the numbers themselves, the contract is really divided in three elements, which we lay out here, how they grow from FY23 to FY26. There is a base budget of the workforce plan of the identified needs at each facility today. That is the dark blue box on the slide you see in front of you. Then there is the light blue box, which is predominantly the cost of living adjustments negotiated with the city and Doctors' Council, as well as other guaranteed increases in PAGNI's overhead and in base physician compensation that we provide for in this arrangement. But the important change and innovation in this contract is this red box at the top, which is an additional earning potential for PAGNI and really for Health and Hospitals as well, that grows from $28 million in FY23 to $51 million in FY26. And on the next slide, we go into a bit more detail about what that is and why it is so helpful for us at Health and Hospitals and for our physicians at PAGNI. PAGNI's recruiting challenges and limited infrastructure required new investment, and this contract does that. That keeps us from having long-standing vacancies. It helps us retain mission-driven physicians who really make our system work. But we have set up a structure where PAGNI will be really deep partners with us on our success in value-based payment. And that takes a few main forms. First, it adjusts the carve-out structure of how we fund physician compensation to really align our incentives from the first dollar that is earned through PAGNI's billing at the physician level. It sets up new revenue sharing on each new attributed member that Health and Hospitals gains through its value-based payment arrangements, revenue sharing on the risk surplus that is generated through our major value-based contracts, and then revenue sharing on the quality bonus payments that we get through those contracts. So those are the critical revenue streams for Health and Hospitals through our value-based contracts, and they will now be central revenue streams for PAGNI under this arrangement. So it's a very important aligning of incentives and sets us up for real success on that front going forward. So those are the key steps forward on the revenue sharing. The alignment and unification of PAGNI's faculty practice plans is also a very important step forward for us to both boost revenue and improve our compliance and just overall organization. So those are critical steps forward on the financial side. We've also partnered deeply with PAGNI on recruitment and retention of a diverse workforce, and I'll turn to Dr. Allen to talk a little bit about how we are moving forward with them on that.
For the record, I'm Dr. Michelle Allen, System CMO and Senior Vice President. As you can see on the graphic here on the slide, looking at the racial and ethnic distribution of our patients as opposed to the racial and ethnic diversity of our providers, currently 92% of the H&H patients are non-white. And 60% of the PAGNI providers, which includes residents, dentists, and pharmacists, are non-white. However, if you look at the percentage of African-American providers, it's 14%, as opposed to nationwide, 5%. The percentage of our providers, PAGNI providers that are Latino is 8%. And if you look at the national prevalence of Hispanic providers, it's about 5.8%. All that to say, even though PAGNI has a greater diversity than on the national average, we recognize that there is more work to do because we do not reflect the racial and ethnic distribution of our patients. What PAGNI has agreed to do, along with the fact that the contract increases the recruitment investments by more than 50%, so where it was previously $2.2 million annually, the dollars set aside for recruitment are now $3.5 million. 1 million of that or more will be focused on recruiting underrepresented minority physicians who better reflect our communities. PAGNI, to that end, has initiated their diversity, equity, and inclusion focus by engaging Willis Towers and Watson to assess their current policies and practices. The engagement is slated to begin next month in May. Based on the results of the external assessment, a strategic plan will be developed to recruit, to retain, to develop, and promote underrepresented minorities in medicine. The strategic plan will incorporate the following: identifying DEI metrics and goals to be reported into H&H on a regular basis, to identify recruitment and marketing partners who have a proven expertise and success in recruiting underrepresented minorities in medicine, and to develop partnerships with minority-serving institutions such as medical schools, the HUBCs, nonprofits, and community-based organizations, with the aim of working with health and hospitals with our current Pathways to Medicines, Mentoring in Medicine, and the Mosaic program focused on increasing the diversity of our workforce. We are currently here at H&H working with such institutions as CUNY, Morehouse, and the University of Puerto Rico. So PAGNI has committed to collaborating with us in our initiatives to not just recruit, but to retain, promote underrepresented minorities in medicine with the overarching goal of delivering equitable healthcare to our patients.
Great. Thank you. A very important step forward for us to build upon our leadership in this area. So we're pleased to present this to you today and ask for your support in moving forward and deepening our partnership with PAGNI. It's an important step forward for the system, and would be happy to take any questions that board members have.
Thank you so much. Any questions from board members?
I know we're talking about PAGNI.
Barbara Lowe,
Thank you.
thank you.
I'm sorry to talk before you acknowledge. Must be a hot one. I know that PAGNI is a physician organization which we've been engaged with for a while. I was just wondering, are we ever bringing in nurse practitioners, to do some of the work that it would be actually appropriate for a nurse practitioner?
We do have nurse practitioners employed by PAGNI, as well as nurse midwives and nurse anesthetists.
Yeah, it's been a while since I looked at this whole paradigm. Thank you.
Hernandez Pinheiro.
I just, not directly related to this, but in some ways it is because of the recruitment component, just general recruitment as well as more targeted recruitment. Do you have a sense of what the turnover is at PAGNI? Okay, I'm just curious about, because that factors in obviously into our efforts to do targeted recruitment as well as general recruitment?
So I don't know the numbers compared to other systems. I'd say that beyond a few years, people stay with us.
I see.
I think that
Early
there's a
years.
certain amount of, are we the right organization for their practice?
Right.
And so I think that first 3 years, there's a fair amount of turnover. But my experience is that most doctors who stay with us more than 3 or 4 years through their whole career, because once you get hooked on the mission of health and hospitals, if you can deal with, the fact that, we don't have all the resources, the infrastructure as other places. But if you get really hooked into how great the mission is, then I think most people spend their career here.
The other thing I would just add, to one of the statistics is that 25% of our doctors are over 60, right? So we're also
Right.
thinking about
That's
that
what
pipeline going forward. They've served the mission very well, but over 60 years old. Hopefully they stay longer, but it is.
Right.
100% of the CEOs of this organization are over
Yeah.
60.
CFOs too.
I would just like to.
Can we talk about the board members too?
Questions from board members?
You spoke about the issue of retaining young doctors and the problems involved there. Is there anything in the contract which addresses itself to the retention of young doctors? Are there any financial incentives to try to keep them on board?
Yeah, I think it's an excellent question. And as Michelle had mentioned, Mosaic is in its infancy. And one of the things that we really want to focus on is loan repayment programs, which, there are some very generous federal programs. The state budget had added money for doctors across New
This
York.
for medical school?
Yeah, for medical school.
Mhm.
We'd also like to, see if we can, tap into scholarship programs. So actually avoiding the student having to incur such large debt. It's very expensive to go to school now. So to the extent that we could develop more grant programs and scholarship programs with the understanding that they would commit to health and hospitals at the end of their educational experience. That is certainly something we want to try to explore via Mosaic. And we're fundraising around that effort too.
Thank you, Jim.
Thank you. Okay, so let me then ask for a vote on this. Dr. Katz,
Yes.
Erin Kelly,
Yes.
Dr. Calamia,
Yes.
Dr. Martone,
Yes.
Dr. Morse,
Yes.
Dr. McRae,
Yes.
Karen Saint-Hilaire, Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñera,
Yes.
Anita Kawadra,
Yes.
and Jose Pagan, yes. So the resolution passes. Thank you so much. Thank you for all the work, and excited to continue working with Pagan for years to come. Let's move to number 5, Dr. Calamia.
Thank you. Authorizing the New York City Health and Hospitals Corporation, the system, to execute a 3-year contract with EAC Network for services to operate the Community Reentry Assistance Network, CRAN, program to assist persons detained by the New York City Department of Corrections as they leave detention and re-enter the community, with the system holding 2 one-year options to renew for an amount not to exceed $25 million over the entire potential 5-year term. This was presented at the Medical Professional Affairs Committee on April 11, 2022, and was approved unanimously for presentation and approval by the board. Thank you.
Thank you so much, Dr. Calamia. So before we go through the presentation, I will note for the record that I have received 2 requests from Mrs. Amanda Lugg, Interim Co-Executive Director of African Services Committee, and Ms. Chris Norwood, Executive Director of Health People and co-founder of Committee for Driving Recovery, to present to the board regarding this item. So I've got both requests and would like to inform Ms. Lugg and Ms. Norwood that according to the public presenters policy, they will be allowed to present their written remarks as submitted to the board office and share with all board members for 3 minutes. Time is not transferable. So on your screen, there is an electronic timer that will provide warnings about the expiration of your time. A yellow light will indicate that the speaker has 1 minute remaining in the allotted time. A red light will signal the speaker's time has elapsed, and a flashing red light signifies that the speaker has exceeded the time allotment and will be asked to close your remarks. So this is not a question and answer forum also. So let's Ms. Lug first, right? Thank you. And welcome.
Ms. Log, if you can unmute yourself, please. Thank
Got
you.
it. All right, thank you very much.
Thank you.
Good afternoon. Good afternoon, and thank you for the opportunity to speak today. With regards to action item number 5, and this contract is an example of a missed opportunity to continue the groundbreaking work of New York City Health and Hospitals' successful partnership with the city grassroots community-based organizations that have been employed throughout the COVID pandemic in the form of test and treat contracts. Community partnership contracts which all agree have surpassed all expected output. African Services is in our 40th year of serving New York City's African immigrant communities, and AC's African Services T2 contract was extended, and we'd even been granted a reduction in our oversight given the consistent completion of required milestones for in-person encounters. But don't take my word from it. For it. An email from someone whose name will remain anonymous from Health and Hospitals emailed us to say, quote, your ability to engage our communities, including some of the hardest reached New Yorkers, has made an incredible difference and ensured that we are doing everything in our power to keep our city safe. In their recent preliminary budget report, New York City Council asks that $50 million be allocated for our own public health corps to focus on COVID outreach and recovery efforts and other chronic health diseases screening methods by partnering with CBOs and FBOs who've already been engaged in this effort. Isn't this the type of investment, the type of racial health equity that H&H have been committed to working towards? We've built this framework through T2. We can't stop now. Thank you.
Thank you so much, Ms. Lug. And Ms. Norwood?
Yes, 1 second.
Yep, good afternoon, yeah.
Alrighty. Good afternoon. Thank you very much for your attention. EAC is a large organization which provides most of its services in Nassau and Suffolk counties, and in fact opened a large new corporate headquarters in Nassau County just this month. It is inappropriate at any time to allocate $25 million to non-New York City organizations for services which can be well provided by New York's own community groups. But at this time of painful community grief, hopelessness, and high unemployment, it is outrightly unacceptable. H&H currently, through its T2 programs, has contracts with 35 community groups to provide COVID-19 prevention and vaccine linkage. T2 work staff includes many outreach workers, which means many have a criminal justice history. Today, these outreach workers, who were the first folks out there and who took the most risk, are also the first scheduled to be unemployed and decontracted from the overall public health corps. No doubt part of EAC's multi-million-dollar assignment would be to get reentry people jobs. But here we are watching dozens of great reentry people who helped save the city left jobless. Let's think larger. Let's think what T2 represents. It represents a major, major step forward. For the first time, there was an infrastructure which enabled DOH, MH, H&H, and community groups to work together. H&H was key to that. It led an actual historic accomplishment in public health. That is why we are not just talking about this EAC contract. What we need to focus on is to all work to keep the T2 infrastructure, including the CAB, or the Community Advisory Board, in place so we have continuing means to seriously plan together. Communities Driving Recovery is a citywide coalition. We want to work with H&H as we did during the worst of the pandemic to now proceed to the most effective recovery. That recovery can only succeed if it is rooted in community and the skills and dedication of the community to rebuild health. Right now, for example, despite the disaster of diabetes, I doubt H&H is supporting any diabetes self-management groups at accessible community locations where patients with type 2 diabetes could learn proven self-management. H&H has had its own models. I especially recall the peer specialist demonstration project some years back, which slashed re-hospitalizations for patients with both chronic disease and behavioral health issues. Let's anchor that at community groups. Throughout the city, you need real care entry, linkage, nutrition services, and yes, re-entry services. But most of all, given H&H's accomplishments during the pandemic, let us not just stop. We're requesting this board of directors to give its own strong support to the city council's request for $50 million in community public health funds, money that can take us forward on a new road of community partnership that works, that creates health, local jobs, and above all, healing. Thank you again for your attention.
Thank you so much, Ms. Norwood. So now we move on to the presentation.
Good afternoon. Thank you for hearing us. My name is Patsy Yang. I'm the Senior Vice President at Health and Hospitals for Correctional Health Services. I'd like to introduce Ms. Ellie Epstein, who heads up the program for our reentry services and transition services. She'll speak directly to the proposed contract before you.
Hi, good afternoon. Thank you so much for having me. My name is Ellie Epstein. I'm a Senior Director with Correctional Health Services, and I'm here today to request permission to enter into a contract with EAC Network for Community Reentry Assistance Network Services, better known as CRAN. The CRAN contract provides reentry services for individuals who've been incarcerated in the New York City jail system, with a particular emphasis on those receiving mental health treatment while in custody. CRAN provides case management services for up to 6 months post-release and a wide array of one-stop shop style services, such as assistance applying for benefits and housing. CHS is actually legally required to provide these services to patients receiving mental health treatment in custody as a result of the Brad H. class action lawsuit, which was settled in 2000. These services were originally provided for under 5 separate contracts known as LINK and SPAN. However, having multiple vendors presented challenges for clients in accessing services, complicated outreach efforts, and made holding vendors accountable difficult. Therefore, these contracts were reorganized and consolidated in 2017 into what is now known as the CRAN contract. Next slide, please. EAC Network is the current vendor, and their contract is set to expire at the end of June. Engagement with CRAN is completely voluntary, and service plans are unique to each participant. Although CRAN strives to connect everyone to care in the community, clients are not required to accept specific services or attend appointments. That said, more than half of seriously mentally ill clients who engage with CRAN post-release are successfully connected to treatment. Approximately 1,800 clients a year were served by this contract. 96% of those who connect with CRAN in the community receive at least one meaningful service as defined by correctional health. That includes things like help picking up prescription medications, providing transportation to appointments, and completing benefit applications. In the last 3 years, they've made over 3,000 unique referrals to engage clients in treatment, education, and vocational programs, and to secure housing. As I'm sure you're all aware, this can be a difficult patient population to engage, and CHS is happy with the quality of service provided by EAC. In addition to providing clients with the services they request, EAC has successfully met all the performance metrics required under the Brad H. settlement, which includes making thousands of calls to outreach clients and confirm connections to care. Finally, the historical budget for the program is listed here, and the new award will be capped at $5 million a year. Although we are expanding the patient population able to receive CRAN services and increasing the scope, which I'll discuss in a minute, we aren't increasing the budget as the total jail population has decreased significantly since the last contract. Next slide, please. Although CHS is satisfied with EAC's performance, there have been some challenges over the course of the contract, and we're taking this opportunity to make some changes. As I mentioned, we're legally required to provide these services to individuals receiving mental health treatment while in jail. Therefore, the original iterations of this contract limited scope service to that patient population. The new contract will expand eligibility and access. Post-release services will now be available to anyone who has been recently released from New York City custody. We've also expanded the eligibility criteria for case management services, which were historically only available to patients with serious mental illness. Moving forward, patients with neurocognitive or neurodevelopmental disorders, less serious mental illness with co-occurring substance use disorder, and people with other significant healthcare needs will be able to benefit from this greater level of support. Finally, we're expanding capacity and expectations around outreach and engagement. The new contract will provide for Friday evening and weekend support and emphasizes provision of cell phones and community escorts. Next slide, please. I realize this is a little dense, I apologize, but this is a large contract, and as such, there are significant expectations of the vendor. The contract requires the vendor to provide case management services and a range of essential reentry services, including helping patients get their prescription medications and connect to treatment, helping people secure identification, completing benefit applications, and providing housing assistance. They must offer walk-in services and, as required under the Brad H. Settlement Agreement, maintain client-facing office space in all 5 boroughs within a half-mile of the courthouse. In addition to providing on-demand services during business hours, they have to have crisis intervention services and support available to clients on evenings and weekends. CHS is the primary referral agency for these services, and we work very closely with the vendor to ensure that patients get the support they need both pre and post-release. In practice, we're in daily communication with CRAN staff, which generally provides good insight into their practices. However, more formally, the vendor is expected to provide line-level reports and a monthly selection of charts for review on, a random selection of charts for review on a monthly basis. They also participate in bi-weekly case conferences with CHS social work and leadership. Finally, the contract includes the performance measures outlined, and which include requirements such as admitting 75% of people referred for case management and providing clients with at least 1 requested service. Failure to meet performance targets can result in financial penalties. Next slide. This is just a brief summary of our procurement process. The solicitation was public and open to all agencies with a 501c3 nonprofit designation. We actually only received 1 proposal, which was from our current vendor, EAC Network. Normal Health and Hospitals procurement procedure was followed, and the committee scored the proposal, awarding it an 8.9 out of 10. Next slide, please. As EAC Network is the incumbent, we're very familiar and satisfied with the quality of services they're able to deliver. They have significant experience providing services to this patient population, navigating the criminal legal system, and meeting the service and reporting requirements of the Brad H. Settlement Agreement. It's also worth noting that our confidence in EAC has been echoed by many other providers in the space, and they actually submitted 18 letters of support along with their proposal. Next slide. As you may be aware, nonprofits are exempt from the MWBE waiver process. However, it's worth noting that EAC does have a diverse workforce. Although they do run programs throughout the state, including in the prison system, close to half of their workforce serves New York City programs, and almost 70% of their city programs workforce identify as people of color. Finally, the contract also requires that they be able to provide services in the language of client's choice and to employ peers as part of the team. Next slide. So to summarize, CHS is requesting permission to enter into a contract with EAC Network for CRAN services. This would be a 3-year term with option for 2 one-year renewals. The total cost is $25 million, which is fully funded through CHS's budget. As they are the incumbent, we anticipate minimal time for transition, with the new contract starting in July of 2022. Again, I thank you so much for your time and consideration, and I'd be happy to answer any questions you may have.
Thank you so much. Any questions from board members?
Just a terrific contract.
Sally Hernandez Piñero.
Terrific contract. Great work.
Okay, so I'm gonna then ask for a vote. Dr. Katz,
Yes.
Erin Kelly,
Yes.
Vincent Calamia,
Yes.
Patricia Martone,
Yes.
Michelle Morse,
Yes.
Michael McRae, Karen St. Hilaire, Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñero,
Yes.
Anita Kawatra, Anita, and Jose Pagan, yes. Okay, Thank you so much.
Thank you very much.
Thank
you.
Thank you for the great work you always do.
Let me move to the next one then.
Always in my prayers.
Thank you, Papa.
Thank you.
And it's number 6 in your agenda. It's authorizing the New York City Health and Hospitals Corporation, the system, to execute a 3-year contract with Derive Technologies LLC, Derive, for services to maintain workstations on wheels and medical carts, with the system holding 2 one-year options to renew for an amount not to exceed $6,500,000 over the entire potential 5-year term. And this was presented to the Information Technology Committee on April 11th, 2022. Yes.
Thank you. Thank you for the opportunity to present today. I am Kim Mendez, the corporate CIO. I'm joined here with Jeff Lutz, who is our Chief Technology Officer. And our request today is focused on the workstation on wheels and the medication carts maintenance contract renewal. Jeff, as well as our partners in supply chain, led the RFP. And Jeff, I'll turn it over.
Thank you, Kim, and thank you, board members. Again, Jeff Lutz, Chief Technology Officer. And today we're here to talk about the maintenance of our carts, which are the workstations on wheels or medication carts that are currently used throughout our system to help provide care to our patients. And the areas that this maintenance covers is, so you see some examples or pictures there, is everything below the computer, if you will. So reconditioning the batteries, all the wheels, and any of the other mechanical items that are on there. We do have approximately 3,000 documentation carts and about 1,000 medication carts that are present throughout the system, provided by multiple vendors. And these vendors typically use a partner like we do today, using Derive, that is certified to provide support for these types of devices. And as mentioned, Derive is an MWBE, and we've been using them over the past few years. Next slide, please. And so with the solicitation, we did a solicitation out to 11 vendors. They were actually all MWBE vendors. We had partnership with supply chain. They were able to identify a large pool of potential MWBEs. Derive was the highest rated proposer out of the 3 proposals that we had received. And they are an MWBE, both city and state certified. And we are looking to enter into a 3-year contract with 2 one-year renewals, and for not to exceed of $6.5 million. Next slide, please. So again, the procurement went through the months of February and March. We'll actually go to the next slide, please. And they had to be MWBE certified, have experience in supporting these types of devices throughout a similar size system. And we did evaluation based on their experience, cost, as well as the overall proposal for the service. Next slide, please. Again, thank you to our supply chain team. It was we had 11 MWBEs that we identified. 3 ended up soliciting, and Derive was the highest ranked winner. Next slide, please. So in summary, we are looking to enter into a 5-year agreement with Derive Technologies. So again, 3 years, 2 one-year renewals to provide support for the current fleet of documentation and medication carts, not to exceed $6.5 million. There is a termination of convenience at the discretion of New York City Health and Hospitals. Any questions?
Thank you. Any questions? Sally Hernandez Piñero.
I'm sorry, maybe you can refresh my memory. We had a large contract where I thought we bought all new carts for putting out medication. Did they not come with maintenance, or are these a different set of carts?
Oh,
both.
Yeah, it's both. They cover both, but because these companies are very small, they don't provide their own resources to cover the country to come out and provide both the preventive maintenance.
Right.
So they make sure the batteries are still running and things, as well as do those break fixes. So they leverage partners like these to help do that in that service for us. So it's not part of their cost. That's how we as opposed to somebody larger like a Dell Computers.
Right, right.
Yeah.
Okay, Barbara Lowe?
Yeah, I understand that documentation is also being done on these carts as
Correct.
well.
Yes.
And that's not only by, let's say, the nursing staff, but it's other providers.
Actually, it supports all of the clinicians who are utilizing the workstations on wheels, as well as it's supporting the
And we don't have
medication.
this going on, right?
No, no.
The nurses waited forever to get their carts 13 years ago, and they were too big, but we did it anyway.
Yes.
But it is wonderful to know that you have this kind of technical support so that documentation is more clear and more appropriate and timely. That's a big factor in delivering care and communicating within the institution and within the teams. So congratulations on this particular contract. It's overdue. Thank you.
Thank you. Okay, so let me then ask for a vote. Dr. Katz?
Yes.
Erin Kelly?
Yes.
Vincent Calamia?
Yes.
Patricia Martone?
Yes.
Michelle Morse?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Anita Kawatra? And Jose Pagan, yes. Thank you so much.
Thank you.
Let me move to the next one. Resolution approved. So number 7 on your agenda, authorizing the New York City Health and Hospitals Corporation, the system, to execute a 5-year revocable license agreement with T-Mobile Northeast LLC to operate a mobile cellular communication system on an approximately 1,600 square foot parcel of land located on the campus of the former Neponset Healthcare Center, located at 67 Rockaway Beach Boulevard in Queens, at an occupancy fee of $50,000 to be escalated by 3% per year for a 5-year total cost of $265,457. And this was approved, presented to the Capital Committee and approved on April 11th, 2022. So
Good afternoon, Chair. Christine Flaherty, Senior Vice President, Office of Facilities Development, joined by Leora John Teff, AVP of Real Estate and Housing. The background to this resolution is that we have a vacant former Neponset Health Center at 67 Rockaway. In 2019 and 2021, the board authorized a 3-month license agreement for T-Mobile to temporarily use the space there for a mobile cellular communication system to enhance cellular communications during the beach season. The location does not anticipate to impact any ongoing operations or future anticipated work at this site. Next slide. For this resolution, we decided to focus on a long-term agreement so as not to bother the board in the future in the next 5 years. This is for 4-month periods, 2 weeks prior to Memorial Day, 2 weeks afterwards. And this would only take up 1,600 square feet of parcel of land for an occupancy fee of annually $50,000. It will be escalated at a 3-year % per year over the 5-year term for a total of the $265,457. This isn't really a market rate type of deal, but we do think that this is a good utilization of the land, especially during the season when many amazing New Yorkers are using the beach right next door. The term of this agreement, again, is 5 years. There is a termination clause, a revocable termination clause as needed with 30 days written notice. And the next slide is just the resolution itself, which you read into the record. We're happy to take any questions.
thank you so much. Any questions? Okay, hearing none, then I would ask for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Erin Kelly? Dr. Martone?
Yes.
Thank you. Dr. Morse?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Anita Kawatra? And Jose Pagan, yes. So the resolution passes. Let's move to the next one.
Jose, I was yes as well. I think I was on mute.
Thank you. That was Anita Kawat.
Thank you.
Thank
Oh,
you.
sorry.
Let's move to the next one. Authorizing the New York City Health and Hospitals Corporation, the system, to execute a contract with Titan Industry Services Corp. to raise the former Neponsit Hospital, restore the site to a grass field, and erect a lifeguard facility for use by the Department of Parks at NYC Health and Hospitals Neponsit Hospital Center with a 20% project contingency of $3,816,000 for unexpected scope changes due to unknown site and concealed building conditions, yielding a total authorized expenditure not to exceed $22,896,000. And this was presented to the Capital Committee on March 11th, 2022.
Good afternoon, Christine Flaherty, Senior Vice President, Office of Facilities Development, joined by Oscar Gonzalez, our Assistant Vice President of Capital Development Group. Again, we're talking about the former Neponsit Healthcare Center located at 67 Rockaway Beach Boulevard. In 2015, the Board of Directors did enter into a license agreement with New York City Parks Department, and they were utilizing a very small portion of the site for lifeguard operations to sustain those operations. Aside for this discrete parks use, the site does remain vacant, and H&H does incur annual expenses to maintain security and grounds at the site. In 2020, it was flagged for Health and Hospitals that the condition of the site was so dilapidated that a portion of roof had landed in the nearby residential neighborhood, which was of grave concern to Health and Hospitals. For context of Health and Hospitals and our services, the nearest major facility is 7.6 miles away, which is our Coney Island Hospital, soon to be South Brooklyn Health. The background for this project, after touring the site, we really realized the importance and life safety implications of not addressing the need to fully demolish all of the structures on this site. The existing conditions are demonstrate extensive damage, loose masonry and terracotta, roofing lost, missing windows. Most concerning to me as I toured the site with a phone and a light, so because there's no utilities on, was there a sign of people entering the building. There was tagging happening inside the building, which concerned me even more if we would have a tragedy occur because somebody inappropriately entered the property, which is fenced. We are spending $250,000 or more annually at this site. The next slide shows pictures of the site. The walkway bridge actually has collapsed since the time we first visited the site. And as you can see in the middle picture below, a picture I took, is the entire basement is fully flooded. You can't even access it. So we commissioned a designer to come on board and really fully assess the site and appropriately look at what could be done with the project. We engaged with the Parks Department, given their use, and we wanted to have a comprehensive solution here that would also think through the process of supporting the city's function of the lifeguard station. And so while we originally contemplated two projects, one for us and one for Parks, we wrapped them together. And the scope here involves demolishing all of the buildings, cellar and basement, removing all of the internal roadways, paths, curbs, and utility tunnels, as well as obviously removing all the hazardous materials from the site. Next slide. This shows you the completed project, which would include installing a new lifeguard station closer to the road, connecting to the new utilities, as well as a parking field for the use of the Parks Department, grading the site fully, providing soil seeding, and a small green infrastructure area for stormwater retention as required by the environmental standards. The project did complete the appropriate SECRA and SHPO regulatory requirements, given that this is at a very vulnerable area of property in the city directly adjacent to Federal Beach. This is the total project budget. We are pursuing city capital for this. Our CP is in with OMB now, so we're working through the CP process. And this shows you the construction, the design, construction management fee, as well as a 20% contingency given potential unknown conditions. And we are doing a more robust community engagement starting in the month of May. Next slide. This was sourced via public bid. We had 7 bidders. The MWBE utilization plan includes a 30% participation from the suppliers and service providers listed there, which shows a $5.7 million MWBE participation. This vendor does not have a passport evaluation in MOX because they haven't been a prime as a demolition provider. They did have 4 references that we did reach out to and speak to, and they definitely provided positive references. We anticipate with, if we are able to get contract registration in by June, we should have a project completion in 2023. The next slide is our request and resolution for the board. We're happy to take any questions regarding this project.
Any questions from board members?
I'm just
Barbara
interested.
Lowe?
Yes, thank you. I'm just interested in knowing how we work with the other non-health component. It seems like there's going to be some integration of purpose, I would think.
Are you speaking about the lifeguard functions? So we'll be working with the Parks Department on a license agreement and determination of property. This is a unique property given the location and vulnerability and given the density of this area of Queens. There's other areas of Queens on the peninsula that we've explored potential services in like the more dense locations of Queens where there are more residents and more services.
Well, I know that for the most part, in areas such as this, where you have a young population often during the summer months, is a unique opportunity to do some health awareness, health promotion. So I hope that some of that happens.
Yeah, I think that, you know, we right now are focused on the life safety piece, but we recognize that not all future thinking about this parcel has been determined, and we look forward to that kind of engagement appropriately. Thank you.
Thank you, Aurora. Any study members?
Just a little point of clarity. The capital funding, is that part of capital funding we would have gotten, or is it an additional request for an additional 25 million directly from the city?
So we currently have a CP approved for approximately 11 to 12 million, which was a point in time. And then we secured in the mayoral budget cycle, the capital dollars. And now we're in the CP approval process for the larger amount now that the bid dollars have come in and we know the final project costs.
Okay, thank you.
Thank you.
Oh, thank you so much. So let me then ask for a vote. Dr. Katz?
Yes.
Erin Kelly?
Yes.
Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. Morse?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Anita Kawatra?
Yes.
And Jose Pagan, yes. So resolution approved. Let's move to the last one. Here, authorizing the New York City Health and Hospitals Corporation, the system, to execute a 3-year agreement with CBRE Group, Inc. for various facility management support services with the system, holding 2 one-year options to renew for an amount with a potential 5-year term not to exceed $100 million. This was presented to the Capital Committee on April 11th, 2022.
Good afternoon, Christine Flaherty, OFD. I'm joined today by Manny Saez, our Assistant Vice President of Plant Operations. In 2012, New York City Health and Hospitals entered into a 9-year agreement with JCI, known as Johnson Controls, to manage the system's plant maintenance operations at a total cost of $498 million and change. This included 50 JCI staff working out of the Office of Facilities Development, including management, finance, critical procurements, and a number of areas of scope. CBRE, that company purchased JCI's facility management business. And during that time, New York City Health and Hospitals renegotiated the contract with CBRE to significantly reduce the scope and scale of that contract. That included focusing on hiring the directors of engineering and assistant directors of engineering, managing the trade staff, and looking to procure many of the maintenance contracts themselves. CBRE currently is only responsible for urgent purchasing with 5 staff supporting the Office of Facilities Development. Next slide. The original contract for CBRE expired on March 15th. We entered a 3-month extension to allow time to negotiate an MWBE plan for CBRE, because at the time of the original contract, this had not been a focus of the contract and there was not an MWBE plan in place. We subsequently, after negotiations during the 3-month extension, entered into a 1-year agreement so that we could determine the future of this scope of services, do an assessment, and give us time if we were going to solicit these types of unique services for our system. The board approved that extension on May 10th of 2021. The current agreement is now set to expire June 30th of 2022, and the current annual not to exceed is $17.75 million for supplies, repairs, and facility support, most of that going towards goods and urgent repairs for our sites, and only $1.75 million of that going towards staffing that are supporting the office itself. CBRE is following OP 100-5 within all the procurements, the urgent procurements that they're executing on behalf of H&H. So the next slide really shows you our journey in the last years as we looked to extend the contract and solicit a new contract for these certain services. I really want to give Manny Saez, our leader here, really accolades towards a very focused effort to increase the MWBE spend. We actually, in this room, held an MWBE fair with all our directors of engineering and the CBRE staff to really have meet and greets and find MWBEs that could do many of the services that previously had gone to other larger scale vendors. And what this shows is really a transition of a tremendous strides of 5.3% in 2018 to 2021 to 15%, and now at 31%. And I'm going to hand it over to Manny now to talk through the work that's done towards this resolution request for the new contract. Thank you.
In addition to the work that's been done with the MWBE, I worked closely with Chief Talby and his team where we increased the target to 35%, specifically because this market, our service providers are readily available. The next slide, please. This is the RFP criteria made up of a good mix of site representation and disciplines. Next slide. Our scope of services, our medley of responsibilities that we were looking for, particularly under urgent purchasing and on-call technical staff expertise. Next slide. Here, this table represents the number of firms invited, MWBE and non-MWBE, the responses, and the award. Next slide, please. This particular slide shows the non-participation vendor feedback. Working closely with our procurement partners, they did their due diligence, their additional due diligence of being able to provide us the areas of feedback that our non-participating vendors had responded with. Here is the vendor evaluation form, which resulted in excellent for this firm. Here is a list of MWBE firms that we use in the utilization plan, pretty extensive. And finally, our request to the board for this contract. Thank you.
Thank you so much. Any questions from board members? Let me then ask for a vote. Dr. Katz?
Yes.
Erin Kelly?
Yes.
Dr. Vincent Calamia?
Yes.
Dr. Patricia Martone?
Yes.
Thank you. Dr. Michelle Morse?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Can I ask one question?
Uh,
I should have done it before the vote.
Yes.
It's a large contract and very few vendors responded and one was found not to meet the requirements. Do you think it's just the requirements are just so detailed that it makes it hard to be competitive in the space?
Yeah, I think that that was why we had supply chain do some due diligence around the market, around those we asked to, we went to the whole city record, but we also went specifically to the major facility management firms across the industry. And so that slide 8 is really an important element. It definitely is a specific set of services.
Right.
And it does require diligence around our OP, having a system in place that will allow us to kind of mirror those rules and regulations we have.
Right.
And so it's a niche, I would say. It's definitely a niche. And we have racked our brains a little bit to think, are there other things to do? And we did do during the summer with our senior leadership team across our system, we looked at insourcing this, and it would require even more positions than what this small team is able to do. So I think for those reasons is why we went through the process trying to see if a competitive procurement would warrant other potential providers. And for this specific thing, we did not see that opportunity.
Okay, thank you, Christine.
Thank you.
I vote yes.
Thank you. Anita Kawatra?
Yes.
Jose Pagan, yes. So the resolution passes. Thank you so much.
Thank you so much.
Thank you.
Particularly with the work, NWB work, and making this an opportunity for many companies in the city.
Thank you for your work.
Thank you. Thank you very much.
So, what else we got? Dr. Katz, your president's report?
Yes, so every month, we're in a new phase of the coronavirus, but the current phase seems to be promising. Cases are up. We have more and more cases of BA.2. But what is remarkable is despite the increase of cases, we still only have 4 patients in the 10 hospitals in the ICU with COVID. And not all of them are even in the ICU because they have COVID. Some of them have other contributing causes. So what's happening is that at least within New York City, where there are high vaccination rates, high rates of prior exposures, the increase of cases isn't turning into a large number of sick people. In terms of total hospitalizations, the numbers have been hovering in the low 40s, of 43 patients. Again, remember, this is over 10 hospitals. We're talking about most hospitals not having any ICU patients and having an average of 4 patients in the hospital with COVID, despite, while people always say, well, hospital numbers lag, the uptick is now about 4 weeks old. And so what you're seeing is a decoupling of the cases from severe illness. And again, I think it's the high vaccination rates, the high pre-exposure rates, people getting treatment with Paxlovid or one of the monoclonal antibodies. So I'm very hopeful. I always like to remind people the virus that caused the 1918 pandemic still circulates as H1N1. But we as humans have learned to live with it after 3 years of, really deadly disease. And I'm hopeful that COVID, at least in populations like ours, different story in places where vaccination rates are very low, different conditions, but that in populations like ours, we've seen the end of large-scale morbidity. Of course, we still feel bad for anyone who is sick, anyone who's suffering from long COVID. Very proud. We talked about the 212 COVID-19 hotline before. People are calling it. People are getting drug directly sent to their homes without ever having to go out, which I think is amazing. We've developed an early career psychiatry leadership program to develop the next generation of Dr. Charles Barron. And we need many, many great psychiatrists who can function in leadership roles and public settings. We were proud to eliminate the 6-month residency requirement for enrollment into NYC Care. This will bring a likely large number of new members to the program so they too can benefit from having a primary care doctor. No surprise that 4 of our hospitals have been ranked among the 50 most racially inclusive hospitals in America. It is something that we very much pride ourselves on. Harlem, Queens, Lincoln, and Metropolitan received high marks for how well they serve people of color in their surrounding communities. Similar vein, my chart, which is part of EPIC now, is in simplified Chinese. This is not something EPIC did. EPIC, we were already able to get it in Arabic, French, and Spanish because they had developed it. But we felt that there was a major need for simplified Chinese, given who we take care of. And so we developed the adaptation, which will allow our Chinese-speaking patients to also use the web portal. We were recognized for our role as healthcare equity leaders for the LGBTQ positive population. The state has released its proposed 1115 waiver amendment this past month, and they're requesting public comment, which we will provide. That's my report, Mr. Chair, and happy to answer any questions.
Thank you so much. Any questions from board members? Okay, thank you.
Very good.
Thank you
Thank
so
you.
much. Very encouraging news on the COVID side, and looking forward to hear what happens with the 1115 waiver and how that plays out, right? So the committee reports, and subsidiary reports, the committee reports were emailed to you and adding your folders for your review and submission into the record. Is there any old or new business to come before this board? Go ahead.
I'd like to thank you very much for pinch-hitting for me on Tuesday, as you'll be chairing the Community Relations Committee meeting. I'll be in Albany, meeting with legislators. The problem is that I'm meeting from 9 to 3, but it could be 4, and the meeting is at 5. So do I really know I'm going to be doing a 5 o'clock on Tuesday? The answer is no. And that's why, if I can, I'm going to be bringing my iPad with me. And if I can, I'm going to be on the 5 o'clock meeting, but thank you for chairing it. I'll just
Welcome
be
to
on
join.
observing. If on the other hand, I'm going to be with some legislators, part of a group meeting with them, then obviously you will not see me. But thank you very much for agreeing to chair the meeting.
Thank you, Bob. Thank you for being in Albany too.
Absolutely.
Anything else? Okay, so meeting adjourned. Thank you so much.
Thank you. Now, some people might not want to mention the fear of embarrassment.
Thanks, everyone.
At first, I wondered if it was a
Well, they show
fashion
what?
statement. Then I saw the price was there, and I thought that was less likely.